Welcome to the ANNA newly updated CKD modules that address nursing care of the patient with CKD in any setting. I am Leslie Dinwiddie, project leader for these modules. Today, it is my great privilege to introduce our author and presenter of the 7th module, Kidney Replacement Therapy in-Center Dialysis, Gail DeWald. Gail is a nurse surveyor for the National Dialysis Accreditation Commission and has authored a section on hemodialysis for the ANNA core curriculum and is the current president of the Alamo City chapter in San Antonio, Texas.
Thank you, Leslie, for that introduction. And welcome to Module 7, everyone. It is designed to help all healthcare professionals who give care to dialysis patients, who give care to patients with chronic kidney disease and require renal replacement therapy in the form of assisted dialysis in the chronic and acute settings. We're going to describe dialysis population, the dialysis procedures, medications, and management of complications. And we share the care of many of these patients. We hope this information will help you care for these patients and help communicate with us. These slides and modules are dedicated to the memory of Sally Burroughs Hudson. She's a past president of the American Nephrology Nurses Association and a fierce proponent of continuing education for all nurses. Again, this is Module 7, Kidney Replacement Therapy, Assisted in-Center. Our objectives. The following objectives will be our guide in the module about in-center, primarily assisted hemodialysis. At the end of the module, you'll be able to describe a basic plan of care for the patient with chronic kidney disease undergoing in-center hemodialysis. You'll be able to explain the care of the patient during the interdialytic period. You'll be able to discuss interdialytic care of the patients on hemodialysis in the hospital and long-term care settings. And you'll be able to outline the self-care that the nurse should teach the patient on hemodialysis and their family. And last but not least, we'll discuss a little bit about assisted peritoneal dialysis. So here's a map of the United States provided by the United States Renal Data System. This map is open to the public, so you can find it if you Google USRDS. This map goes through the incidence of ESRD patients in the 2020 to 2021. Now, these are the prevalent patients with kidney failure, and prevalence means they are all the dialysis patients that are on dialysis or had transplantations are included in this schematic. So you see the really dark areas. Those dark areas are 3,000 per million populations of patients with kidney failure. You can see the South Texas region, the Valley of California, up in the Dakotas, the West Virginia area, and also along the Mississippi River from St. Louis down to even below Memphis. There we see a lot of dark areas. So these are places where many of the patients are on dialysis or have kidney failure. So this is our most complicated slide, but it is the incidence and prevalence graphs that the USRDS has provided. So on the left, we're seeing the incident patients from 2001 to 2021. And you can see that the amount of patients has grown. And we have 113,000 patients on the blue line, and those are your hemodialysis patients or staff-assisted hemodialysis patients. Those patients starting home hemodialysis, which is the red line, is very low at 500, but it has gone up over time. Much larger was the number of patients who initiated peritoneal dialysis, which reached over 16,000, and that's the gray line on the left. And the green line are the preemptive transplant patients. They counted for 4,000 people in 2021. That is an all-time high. When we look at the graphic on the right, it is the number of prevalent patients, or all patients who are receiving kidney replacement therapy. Over 462,000 patients are undergoing staff-assisted in-center hemodialysis. That's actually down 1.5% since 2020. And if you guessed it was the pandemic, you're right. PD, though, increased by 66,000 in 2021. So we grew a lot of PD programs and PD patients back then. And functioning transplants increased to over 251,000. That's your green line. Look how much it has increased since 2001. So we're going to do an overview of in-center hemodialysis care. We see our little lady here sitting in her lounge chair next to a dialysis machine. It has a dialyzer on it, and she's actually next to the fire extinguisher. So anyway, this is a typical patient in a typical dialysis center. They usually do a 3-day-a-week schedule that is either Monday, Wednesday, and Friday, or Tuesday, Thursday, and Saturday, and most treatments are 4 hours each. Hemodialysis means cleaning the blood, and access to the bloodstream is needed for hemodialysis. So this slide is showing us the 3 types of accesses that are available. It's the arterial venous fistula, which is there on the upper right-hand picture, the arteriovenous graft, which is the lower right-hand picture, and the central venous dialysis catheter, which is the picture in the middle. We're going to go over those at length later. The blood is accessed and circulates through the dialyzer on one side of the semi-permeable membrane. The ultra-pure dialysate bath circulates on the outside of the semi-permeable membrane of the dialyzer. About 250 cc's of blood is the average amount outside the body at any one time. You see where the needle goes in near the patient's hand, and the blood pump is pulling blood from that access into the circulation through the dialyzer, and then back to the patient through the other needle that's pointed toward the heart. So cleaning the blood, the clean blood returns to the body after it's gone through the circuit. Our patients are very complex, and we need an interdisciplinary team to help care for them. And our dialysis centers have all of these people caring for the patient. We have the nephrologist, the nurse practitioner, and the physician assistant that do the prescription for dialysis and make medical care rounds and are available for phone calls if we need them. We have a social worker who's a very important part of the team. The social worker deals with the patient's quality of life issues, emotional support, transportation, and financial issues. Our patients, our government, Medicare provides government insurance to all patients once they've been on dialysis at 3 months. And as long as they're citizens and have worked enough quarters, they are eligible for Medicare. And the social worker helps us get them on Medicare. The dietitian manages the patients nutritionally. They review labs, they manage patients' bone disease, and they provide patient education. They're a very valuable asset to our patients. The nurse is involved with volume status of the patient, vital signs, cardiovascular and respiratory status, treatment tolerance, and patient safety. The RN is the communicator in the team. We all work together to take care of the patient. Nurses also delegate patient care to the dialysis technicians in our centers. They prepare equipment, evaluate vital signs, initiate treatment, and monitor the patient. They're a very valuable part of our team. And last but not least, we partner with the patient and the family because it is essential to ensure quality of care. So while care of the patient is an interdisciplinary team responsibility, we know that it is the nurse who is with the patient more than any other discipline. Nephrology nurses use the nursing process in providing care to the patient with kidney disease. Detailed standards of care are found in the nephrology nursing scope and standards of practice that you see here on the screen. The core curriculum for nephrology nursing and the contemporary nephrology nursing are two texts that are evidence-based and help guide the nephrology nurse in the day-to-day care of the patients. Patient education is such a big part of nephrology nursing. We must have sensitivity to health literacy and provide individualized care. So some specific components of the dialysis treatment plan require careful consideration and monitoring. Fluid volume status is an important factor of dialysis, nutrition support, medication considerations, vascular access management, and blood pressure management. So for volume status, the healthy kidney rids the body of excess fluid. So that means you and I, with good kidney function, are sitting watching this webinar at our target weight. So it makes sense that one of the major challenges of kidney failure is trying to replace that function, removing the fluid from the patient's body. Most patients are anuric and stop making urine. The excess fluid is removed through ultrafiltration. Ultrafiltration takes place in the dialyzer as water from the bloodstream is forced through the semi-permeable membrane by pressure on the blood side of the dialyzer. The amount of fluid being removed is based on the patient's target weight. And target weight is determined by the provider, either the doctor, nurse practitioner, or PA, and provides a goal for fluid removal during treatment. The patient's weight is measured before and after every treatment at the dialysis center. So that target weight is our goal to meet the patient's body weight free of excess water. Our fluid removal goals, or ultrafiltration, are set based on the difference between the pre-dialysis wet weight and the post-dialysis target weight. So typically, we would remove 0.1 to 1.5 liters of fluid per hour during dialysis to reach the target weight. As an example of target weight, let's say you have a patient that's 70 kilograms at their target weight. They come in for treatment today on Tuesday, and they weigh 72 kilograms. So we have 2 kilograms of fluid to remove, which equals 2,000 milliliters. So that would be 1.5 milliliters per hour is removed from our patient that's 70 kilograms. Recent science advises us not to exceed 10 milliliters per kilogram per hour for patients' cardiovascular safety. Patients should achieve their target weight by the end of every session. Target weight is re-evaluated every treatment. The nurse looks at it and compares with the last treatment, maybe confers with the dialysis technician and patient, and decide on our fluid removal. Fluctuations are based on solid body weight gains or losses. I was just in a clinic last week and a patient was on Ozempic, and they were having to decrease her target weight every week because she's been losing almost a kilo every week. So when a patient leaves over their target weight, like 1 kilo or more over their target weight, they are hypervolemic. That means they may have hypertension, they may still have edema, shortness of breath, dyspnea on exertion. If a patient leaves below their target weight, then they have volume depletion or hypovolemia, and they may have dizziness, lightheadedness, hypotensiveness, and or muscle cramps. So the dietitian makes individual recommendations on nutrition guidelines and goals. So generally, the guidelines for kidney failure, we increase the protein for our patients to 1.0 to 1.2 grams per kilogram per day, of 50% of it being high biological value. So high biological value means chicken, fish, eggs, meats, and for our vegetarians, protein foods, maybe some beans and some tofu or things like that. So if you actually look at that, how much protein it is for our 70-kilogram patient, it would be 10 to 12 ounces of high biological protein per day. That's a lot. Sodium and potassium are also restricted. Potassium, when it is over 5.5, can be dangerous to the patient. It causes alterations in the heart, in the EKG, the rhythm of the heart. So 40 to 70 milliequivalents is the recommended amount, which is 1,500 to 2,500 milligrams per day. The normal human takes in about 4,000 milligrams a day. Sodium at 750 to 1,000 milligrams is a restriction. The ADA recommends no more than 2,000 milligrams per day of salt. Phosphorus is restricted to 600 to 1,200 milligrams per day, and calories are actually upped to 35 kilocalories per day, per kilo per day, and that equals, for that 70-kilogram patient, would be somewhere around 2,500 calories a day. So medication considerations: dialysis-specific medications are needed to treat anemia, mineral bone disorders, and high blood pressure. So let's talk about anemia. The normal functioning of the kidney has a part The normal functioning kidney has a part to play in producing red blood cells. The normal kidneys release a hormone, erythropoietin, which stimulates the bone marrow to produce new red blood cells. Many patients on dialysis have anemia due to the fact that the kidneys only produce a small fraction of the epogen needed, or EPO needed. So we have a lack of erythropoietin in our system, and the treatment for that is giving erythropoiesis stimulating agents. We have many of them on the market today, and they are usually, they're always an IV, or they can be IV or sub-Q injection, excuse me. Since the late 1980s, we have been able to replenish the hormone with erythropoietin stimulating agents. There are many forms, and they are injectables, and we also can give iron because iron deficiency is common in our patients. It hinders the red blood cell production also. So we give IV iron in the treatment, during the treatment, when it is ordered by the provider. Bone mineral disease and dysregulation of vitamin D, calcium, and phosphorus is another problem that faces our patients. The diseased kidneys cannot filter out phosphorus and remove it through the urine like the normal human being. So high phosphorus stimulates high phosphorus in the blood stimulates a decrease in the calcium in the bones. It actually pulls calcium out of the bones, and this results in bone disease and bone fragility. Vascular calcification can also occur, and it may be part of cardiovascular mortality. Bone disease is treated with phosphate binders, and you see here on the slide that the phosphate binders are given with meals. High phosphorus levels trigger, besides calcium release, it triggers PTH production, thus increasing the kidney bone-related bone disease, vascular calcification, and cardiovascular mortality. So some of the phosphate binders are here on the screen: Renvela, Foslo, Fosrenol, and Velphoro. There are many, many more to choose from, too many to list here, but these drugs are very important to bring that phosphorus down, and the phosphorus is released through the bowels. Patients need to take these meds when they have a meal or a snack, not an hour before, not an hour after. The meds need to be in their stomach when the food is there. So always remember, if you're in one of those settings, that have them wait till their meal comes to give them those medications. Vitamin D analogs are oral or intravenous and can be given to patients at the dialysis facility. They are IV or oral. Calcimimetics are another drug that can be given. It inhibits PTH synthesis and lowers the PTH and calcium levels. And we have a brand new drug out. It's been out less than a year, and it's a phosphate absorption inhibitor, and it's named Exfosa. And that drug can be given twice a day, does not need to be given with meals, and it does reduce the phosphate absorption in the gut. We also monitor phosphorus and calcium levels monthly. Some patients are monitored more often. So medications for high blood pressure. Elevated blood pressure is a common problem in patients with kidney failure. In fact, hypertension is one of the main comorbidities that causes kidney disease. A lot of times we will admit young patients, 25 years old, in kidney failure. What happened here? They haven't had a doctor's exam since high school, and they've had 4 or 5 years of hypertension that is causing the progression of kidney disease. So, not every patient has high blood pressure, but many of them do. And it can be caused by the increased hormone or renin production and fluid and sodium retention. So the treatment for that is antihypertensive medications. Our patients are on, almost all patients are on antihypertensive medication. Some are on up to 4. They also have the treatment with the low sodium diet and that fluid restriction. So many medications are needed. Many medications need a dose adjustment. Many drugs are contraindicated in the patient with kidney failure, and many others need the dose adjustments due to altered kidney excretion and metabolism. So we have to decrease the strength, the dosage strength, or decrease the frequency of the medication due to poor kidney elimination of medications. You would need to refer to your package insert and drug guide. So let's say it's an antibiotic and the doctor orders a large dose that may not be appropriate for the kidney patient suffering with CKD. So you would need to refer to that package insert to see if a dose adjustment needs to be made. Post-dialysis dosing may also be needed due to the removal of drugs during dialysis treatment. Dialysis nurses have a list in their clinic or their setting that shows the drugs that are dialyzed out, and we often have to refer to that list and make adjustments in medication prescriptions. So drugs that require adjustment, these are just a few, there are many, many, but antibiotics, seizure medication, NSAIDs, IV dye, and gout medication. The vascular access allows blood to be removed from the patient and pumped through the bloodlines through the dialyzer or the artificial kidney and returned to the patient during hemodialysis. Three types of vascular access, as we mentioned before, are the arterial venous fistula, the arterial venous graft, and the central venous catheter. So here's a closer look at the vascular access arterial venous fistula. An artery and vein are surgically or interventionally connected in the arm to make an enlarged high flow vessel, which is the vein, and a site for needle access to dialysis. So you see in the close-up picture where the vein is connected to the artery. So that high pressure in the artery now moves some of that high pressurized blood into the vein, and it fattens up that vein over time. It takes a good 4 to 6 weeks to get AV fistula matured, but once it's there, it is a wonderful access that can last for many, many years. And it is the recommended access for most hemodialysis patients. Across the country, we have about 65% of patients with an AV fistula. An arterial venous graft is an artery and vein that are surgically connected by a synthetic tube. You can see the white tube is there. One is connected to an artery on the right side and then to a vein on the left. Needles are placed in that graft for access to dialysis. Now that tube is tunneled under the skin, so you don't see it except for you see the impression under the skin. It takes 2 to 3 weeks for the swelling to go down and for the access to be ready for hemodialysis. About 30% or 35% of patients in dialysis centers have an arterial venous graft. The CVC catheter, it is the third option and should only be used as a temporary option while a peripheral access is healing or maturing. So a lot of patients come to us with a catheter, and sometimes they don't have another access formulated as yet. But as soon as we get them there within a week or so, we're talking about a peripheral access and maybe even scheduling them to have vein mapping and a look by the surgeon. So CVCs are temporary. About 10% of patients in a dialysis unit have a catheter. We'd like that to be an even lower number. Dialysis and nurses and technicians access the vascular access every treatment. All healthcare providers should be able to listen for the bruit with a stethoscope. The bruit is a noise of the turbulent blood flow through the access. You should be able to feel that on a fistula or a graft. And you should be able to feel the thrill, which is a vibration of the blood flowing through a fistula or graft. I had a patient years ago that I was telling her about checking her access daily for that thrill. And she said that she sits her little granddaughter on her lap and she says, "Grandma, your motor's running." And so that's right. We have to make sure that motor is running every day. So we do have some safety alerts here about access management. We want to make sure blood pressures are not measured in the access arm. And we don't want pressure bandages that wrap around the access and constrict it. We need to inspect needle sites after hemodialysis treatments, make sure they're healing. Generally, we want the Band-Aids or the dressing on a vascular access like a fistula or graft to be removed 4 to 8 hours after treatment. You don't want to leave those Band-Aids on until their next dialysis treatment. We don't ever want to put IVs in that access arm, and patients and all healthcare providers must preserve blood vessels for future fistula creation. So we can have complications in an AV fistula and AV graft, and some of them are these. Infection can occur due to failure of using aseptic technique or poor hygiene of the patients, and it's almost always treated with antibiotics. Stenosis is a narrowing of the access vessel is the most common complication, and it can be caused by scarring of the vessel wall due to needle injury, infiltration, or hematoma formation. Stenosis can also lead to a clotted access, and angioplasty of the access is the treatment for stenosis and usually is done in an access center or in the hospital. Aneurysm is what you're seeing in this picture. An aneurysm is a bulging of the vessel over the vascular access. It's caused by repeatedly using the same cannulation sites. All caregivers need to be on the lookout for this type of complication. Treatment is surgical intervention before the access pressure causes that vessel to erode through the skin and cause profuse bleeding, which can be fatal. So you see the shiny part on that bulge there on that, it looks like it's probably a fistula. That shininess means that the vessel is very close to breaking through the skin. And so we don't want to put needles there. In fact, we want to send that patient as soon as possible to be seen by someone at the surgeon or someone at the access center. Steele syndrome is another complication. It's a painful ischemic condition caused by the access stealing blood from the extremity, usually the hand. Usually a second surgery is needed to repair the problem. If you ever walk through a dialysis unit and see patients wearing a glove on one hand, it's because that's their access arm and their hand gets cold because we've taken some of the blood from that hand and put it into the access. So often those patients have a glove on. There's also high output heart failure from an enlarged AV fistula. All arteriovenous access can cause changes in body hemodynamics, primarily through the increased cardiac output. Extreme cases of high output have been seen in some large arteriovenous fistulas and require surgical intervention to prevent heart failure. So complications of central venous catheters. Here in the picture, you see a problem with infection. So this looks like an exit site infection, but it can move through that tunnel into the heart and can cause endocarditis or septicemia. So it's very important to be on the lookout for any signs of infection. Hemodialysis catheters should not be used for blood draws and medication administration outside the dialysis center. And because of the high risk of complications, catheters should only be used when necessary for the shortest time possible. So here are some safety alerts to prevent infection. No swimming, showers, or tub baths. Change the dressing only if soiled. Report any purulent drainage to the dialysis center and take those daily temperatures. And if they're running a fever, we need to report that to the dialysis center. Catheter malfunction presents with low flows, may be due to poor placement technique, retraction of the patient's catheter, a cracked hub, broken clamps, or thrombus or fibrin sheath formation. In the picture, we see central venous stenosis or central vein stenosis that was caused by a history of central venous catheters in the subclavian vein. We don't see that as much anymore. Back when I was a new hemodialysis nurse about 30 years ago, we had a lot of subclavian catheters. They could be tunneled, they might not be tunneled, but they would cause this venous stenosis. And we would have huge edematous shoulders and arms. The patients were in pain, was very uncomfortable, and had to be surgically repaired, and sometimes could not be repaired. We also have some safety alerts here. The report to the dialysis center nurse if that catheter cuff is exposed on the chest, if there's a cracked hub or broken clamps, if the caps fall off, or if the catheter falls out. Yes, that has happened. Catheters have fallen out while they've been at home or at the hospital. It's uncommon, but it can happen. So we're going to now talk about the components of hemodialysis. Here you see a hemodialysis setup. You see the lounge chair, the water box is back on the wall there. You can see that white frame around it. We have a dialysis machine with a dialyzer and the extracorporeal circuit all set up and ready to go for the patient. So these are the things that are the components of treatment. So let's start with the dialyzer. The dialyzer is also called an artificial kidney. It's a container of hollow fibers that directs blood flow through the fibers and the dialysate flow around the fibers during the dialysis treatment. So you see the depiction here in the drawing. So we have a plastic type outer casing and fibers go along the middle. Those fibers, there are probably 1 million fibers in that within that dialyzer, and they're all about the size of a hair. And they have a they're hollow down the middle, so they're like a straw. So the red blood cells and the serum run through the dialyzer. You see from the patient at the top, and it runs straight the blood back to the patient at the bottom. Then you see the compartments that have a connector that you see dialysate solution from the hemodialysis machine at the bottom, and it flows through and bathes the fibers inside the dialyzer. And the dialysis solution then comes out and goes to the drain in the back of in the wall behind the patient. So the dialyzer removes uremic toxins from the blood through the process of diffusion. Those uremic toxins are BUN, creatinine, phosphorus, and potassium. The dialyzer also removes excess fluid through osmosis and convection, and that's called ultrafiltration. The used dialysate flows from the used dialysate flows from the dialyzer and down the drain. We used to do a procedure that is now done without capturing the spent dialysate, but we would measure the dialysate in a beaker for this one procedure, and the beaker would fill up with fluid that came out of the patient's blood. And when you saw the fluid, it was a cloudy beige color, and it had the aroma of urea or urine. So we know that that's what we're doing to the patients. We're taking off those uremic toxins. So the dialysate or dialysis bath, it's an isotonic solution pumped through the dialyzer on the outside of the semi-permeable hollow fibers. Uremic toxins from the blood will diffuse into the dialysate fluid during dialysis and be discarded. The dialysate bath contains potassium, sodium, chloride, bicarbonate, calcium, dextrose, and magnesium. The dialysis provider, the physician or nurse practitioner, order the amount of potassium and calcium they want for each particular patient. Most of the patients are on a similar bath, but there are a few patients that are on a special bath for their special needs. The dialysis machine is equipped with two separate circuits to pump. So we have the blood pump that pumps the blood from the patient's vascular access through the dialyzer and then back to the patient via the vascular access. Then we have the dialysate that is mixed in the dialysis machine. It goes through the dialyzer and is discarded through the drain pipes. There are sensors and alarms in our machines to detect and alert staff to problems with the flow of blood or the dialysate during the treatment. Water treatment is a very important aspect of hemodialysis. The patients are exposed to about 120 liters of water per treatment when they're on hemodialysis. The purified water mixes with dialysate concentrate to a specific concentration before entering the dialysate circuit of the machine. The water is ultra purified and highly monitored for safety. Nurses and technicians are specially trained for this role in managing water treatment system at each dialysis unit. And the dialysis water treatment is a specialty with strict guidelines and requires expert training. So let's talk about a routine treatment. And your nurse, as a nurse, we would do a thorough assessment, listening to the lungs and heart, looking for swelling or edema in the ankles or in the face or lower back. We look at the vascular access to see if we're good to go today. And we take strict infection control measures, wearing PPE and masks during put on and takeoff of the patient. The routine treatment before, during, and after every dialysis treatment, we have to use infection control. So pre-dialysis assessment starts when the patient enters the dialysis unit. As a nurse, we watch them walk in, or maybe they're in a wheelchair or with a cane. Has that changed? Are they doing something different than normal? So we look at their gait and their balance. The patients may have a complaint since their last treatment, so we need to find out what that is. We monitor vital signs. We weigh them before treatment. And we need to weigh them with similar clothes every time, without coats and blankets and their bag with them. We look at their skin to see their color and if it's warm to touch. We evaluate and assess their mental status and that fluid volume. We look at blood pressure, edema, lung sounds, and shortness of breath, and sometimes even look at pertinent lab data to see, especially if they recently had labs. Routine vascular access assessment is inspection of the skin over the access, palpation of a thrill, and auscultation of a bruit. A bruit is, you should be hearing the whooshing of the blood when the heart is pumping or with the pulse. And if you hear a high-pitched sound, that usually is a sign that there is an obstruction or a stenosis in that access. And so if they're at the dialysis unit and our staff hears a bruit, a different type of bruit than normal, then they will investigate. There is also weekly assessments for signs of vascular access problems, like skin breakdown over the access or a strong pulse, stronger than normal, indicating narrowing of a vessel, and maybe signs of infection. So initiating hemodialysis, we would start with cannulation of the arteriovenous access using skin disinfection. We, with either alcohol, a chloroprep type cleaner, or a betadine. And the needles are inserted. We use 17, 16, 15, and 14 gauge needles. So they're large needles and they're about an inch in length. The needles are secured and the with tape, and you can see the patient in the picture here has their needles in with gauze over the tape. It's always good to put gauze there so we can see any oozing of blood and know that there may be a problem with that needle. Accessing blood from the catheter, we have to make sure we scrub the hub per CDC guidelines. An anticoagulant is withdrawn and both lumens are flushed with saline. Catheter connection and the pump is started, so we're off and running with our blood flow. Blood flow alarms are set and pressures are monitored during the whole treatment. We basically check the patient and the machine every 30 minutes. In a hospital setting, it might be more often because the patient has acute illness. So a routine treatment with infection control creates dialysis precautions, hand washing by patients and staff, and glove changing. You know, patients need to wash their access with soap and water, and at the end of the treatment, they need to use either hand hygiene with a hand sanitizer or wash their hands before they leave the clinic. We must always use aseptic technique. Aseptic technique is sometimes broken when we're putting in we're cannulating the access. You might see staff put the disinfectant on the skin and then they touch right where they're going to stick. So they have actually contaminated the site and have to re-disinfect that site. So we also disinfect the dialysis station between patients. So when one patient is finished, we clean up and wipe down all of the surfaces and then set up for the next patient in most clinics. So infection control is, you can tell it's very important by so many slides on infection control. And you see this poster that the CDC sends out every dialysis unit. I see them posted in the lobby or somewhere where patients can see it. So infection control includes catheter reduction. The less catheters we have, the less infection we have. Rigorous catheter care, safe injection practices, tracking infections, especially vascular access-related infections, and giving immunizations to staff and patients. So staff assisted hemodialysis during a pandemic. If all of you were working during the pandemic, I'm sure you went through all of these steps wherever you were working. So in center, we took a daily temperature of patients and staff. We also screened everyone that came to the clinic to see if they'd had any COVID testing and if it was positive or negative. We asked if they had exposure or if they had been traveling out of the country anytime recently. We also discouraged or prohibited visitors in the center or in the lobby. We had mandatory hand washing and hand hygiene for everyone in the facility. We had mandatory PPE for staff and patients, which included masks. And isolation and separation of those COVID-19 patients occurred, or those that just had symptoms. We would separate them from the main group of patients as best we could. We increased attention to cleaning the environment, and the providers were able to do telehealth visits. So nursing home and assisted living centers during the COVID-19 pandemic, we had a plethora of new dialysis programs established to allow patients to stay at home. And so we saw many nursing homes and assisted livings start a home dialysis program within the facility. So most congregate settings tested all staff and patients and discouraged the same things we did in our clinics. They discouraged and prohibited visitors, had the mandatory hand hygiene, mandatory PPE, and they increased attention to disinfecting the environment and the telehealth visits. So very much the same as what we experienced. So the common interdialytic complications, and that means complications during treatment. These are routine treatment of conventional 3 times a week hemodialysis has taken place for over 50 years in the United States, but even best practices and safety precautions in place, complications do occur. This chart lists the most common events, their usual cause, and the potential treatment for them. The next set of slides, most facilities have standing orders for the nurse to follow to treat these complications. The next set of slides describes the experience and the care that inpatient and long-term care nurses might provide during the interdialytic period, which means between treatments. So the best way to learn about the care of the dialysis patients is to communicate with the staff who have been dialyzing them for weeks or perhaps years. Communication between the long-term care and hospital unit and hemodialysis staff is of utmost importance, especially when the patient is being discharged from the hospital back to the outpatient dialysis facility. The nurse in the long-term care facility establishing a rapport with dialysis staff will facilitate meaningful communication. Learn the names of those who can receive and provide patient information, and they should learn your name too. Providing a report before treatment using the SBAR format is very helpful. And just to refresh your memory, SBAR is you report the situation, the background information, your assessment, and your recommendation. So things you might communicate include recent changes in medication, any falls since the last dialysis treatment, hospitalization, recent hospitalization, DNR status if it changed, recent surgeries or procedures, and allergies, or any significant change in the patient's status since the last treatment. So let's look at the routine interdialytic care for the stable hemodialysis patient. So we ask you to look at vascular access. The fistula or graft should have hemostasis. We shouldn't be bleeding anymore. If bleeding restarts, we need to hold pressure on that site with clean gauze and then redress that with a Band-Aid after they have gotten hemostasis. You want to always listen for the bruit and feel for the thrill and look at the type of dressing the patient has and if it's intact. With a catheter, we look at the exit site condition. If the dressing comes off, we might have to do a dressing change and make sure the end caps are secure and that the clamps are clamped. Vital signs need to be taken per doctor's order in their outpatient setting, and the blood pressure should be on a non-fistula or graft arm, and then, of course, taking their temperature. As a safety alert, we should never use the dialysis access for phlebotomy, and we should never take the blood pressure in the access arm. And most places I've seen post a sign that says no blood pressure in the arm with the access. So we also want to weigh the patient daily, fluid and salt restriction per MD order, administer phosphate binders with those meals and with snacks, and assess the diet and corresponding laboratory values, especially potassium. The complications following dialysis treatment, there are many here. There always is a potential for hypotension, hypoglycemia, cramps, nausea, vomiting, fatigue, or vascular access issues. Hypotension is probably the most common cause most common complication that you will see after treatment, and it's caused from the dialysis center removing too much fluid or removing fluid too quickly during hemodialysis. The potential causes are inaccurate pre-dialysis weight, a pre-dialysis volume depletion, like they came in below that target weight. Maybe they were eating and drinking during dialysis, which most clinics don't allow large amounts of food or drink to be brought in because it makes, when they do have a large meal or drink, it makes the blood tends to go toward the stomach for and causes the vasculature to have a lower load of blood. So that causes the blood pressure to go down. So hemorrhage from vascular access can also occur. Again, you want to hold pressure on that site until it stops bleeding. Anemia is also a cause of hypotension. Too many antihypertensive meds and heart disease can also cause that problem. So the signs and symptoms of hypotension are yawning, feeling dizzy, sleepy, or weak. They have pallor, clammy diaphoretic skin, nausea, vomiting, cramping, chest pain, decrease in mental status, up to a loss of consciousness that can happen in the dialysis center, should not be happening after treatment if the patient left in a stable condition. But it can happen and has been known to happen in a rare occasion, as well as seizures. The treatment for hypotension is to recheck blood pressure for accuracy and postural changes, elevate the legs, give oxygen, evaluate the volume status, review the medicine list for blood pressure meds. Were they given twice, or maybe some were given at dialysis, and you might need to call the dialysis nurse if that occurs. Communicate with the dialysis team, and administer fluids if ordered. So hypoglycemia can also be a complication, and the signs of that are double or blurry vision, that fast or pounding heartbeat, headache, shaking or trembling, sweating, tingling or numbness of skin, and tiredness or weakness. Most of us as nurses know those signs of hypoglycemia, and that big red flag comes up as you're assessing the patient. So the treatment for hypoglycemia has always been to give 15 grams of carbohydrate. But in our kidney disease patients, we want to give them that 15 grams, but not in the form of orange juice, which is very high in potassium. So it's better to use grape juice, apple juice, or one of those emergency gels that are kept on crash carts or in the cabinets for patients that have high blood or low blood sugars. So you want to retest that blood sugar every 15 minutes, repeat the treatment if necessary to keep that blood sugar range from 70 to 115. Have snacks available in the peridialytic period. So when a patient comes off dialysis, they should have some kind of snack, especially if they're diabetic. Muscle cramps is another complication, and it's sometimes when fluid is taken out of the body at a fast rate during dialysis, or too much fluid is removed, the muscles react by cramping. Muscle cramps may occur in the patient's extremities, stomach, and chest, and the cause varies from patient to patient. We need to assure their electrolytes are in good balance. An immediate treatment would be to give them some oral fluids, massage the cramping calf or leg, or have them stand. Standing, though, can be dangerous, especially if they have any dizziness or their volume depleted. So just a caution there. If you stand them up, watch to see how well they have balance. You want to assure patient safety during cramping and communicate to the dialysis center nurse prior to the next treatment that the patient had cramps when they got back home. So patient education, complications can occur after dialysis at home and be frightening and uncomfortable for the patient and family. As nurses, one of our roles is to educate patients, and we need to educate on vascular access, weight and fluid management, blood pressure checks, medications, diet and supplements, schedule of treatments. They're 3 times a week. They don't want to miss their treatment, and complications, and also when to contact their healthcare providers. So for routine care, we want to teach them about protecting that vascular access. We need to keep it clean at all times and avoid injury or injury to the access arm. We want to use blood pressure cuff on the non-access arm and avoid prolonged pressure on that access. Don't wrap dressings around with ace bandages or anything like that. We also don't want them to wear tight-fitting sleeves on that access arm, which can cause the graft or fistula to clot. Also causing clotting could be sleeping on that access arm, and you don't want to have them put their head on their access arm during the night. They need to be aware that they need to turn on the other side to sleep on the non-access arm. And we need to check daily for fluid, for thrill and bruit. What about the patient with a CVC? We want to protect that catheter the best we can by securing it in place, make sure the dressing is dry and clean, and the catheter caps are in place. Use only for dialysis. It's not to be used for any other purpose, and report signs of infection. Patients need to weigh and be aware of fluid management, so we need to teach them about fluid restriction. Not every patient is on a fluid restriction, especially those that still make quite a bit of urine, but most patients are on a fluid restriction. So we want to measure their intake, and we don't want to leave a pitcher of water at their bedside or in easy reach for these patients. We want them to ask for sips of water instead. So we need a daily weight if possible. So the hemodialysis prescription is 3 times a week, about 4 hours per treatment, and it's really important the patient knows they need that 3 times a week 4-hour treatment. Some settings and some machines run shorter treatments, and they might do 4 or 5 days of treatment. It's still important for them to have the doctor-ordered treatment. The treatment duration, if it's 4 hours, we don't want them to leave treatment an hour early, so we try to keep them on their treatment and teach them how important it is, and teach them about volume control and fluid management. The diet and protein supplements, we need to talk with patients about that, even as a nurse. This is a dietitian's specialty, but as a nurse, we should know what these patients basically need. So we need that high biological protein intake, low potassium foods, which would be high potassium foods are banana, orange juice, avocado, beans if they eat too many beans, and then dark sodas. There are many sodas that have high phosphorus. Or, I'm sorry, we were talking about potassium, but potassium is a problem with a lot of our fruits and vegetables, so be aware of that. Low phosphorus, patients need to be on a low phosphorus diet. Most of our phosphorus foods are foods that are dairy products, cheese and ice cream and milk. Today we have lots of options with non-dairy ice cream, which are always better choices for our patients. And also phosphorus is in dark sodas. So Coke, Pepsi, the only dark soda without phosphorus is root beer. So root beer is safe for these patients, as well as Sprite and orange flavored soda, not orange juice. So we also want to teach them about low sodium diet, and we do that so that it curbs their thirst. You know, if you eat something very salty in an hour or so, you're very thirsty. So the same thing happens with our patients. And that fluid restriction is also another point of education. And avoiding salt substitute products. They are almost always high in potassium. So what about blood pressure? We need to teach patients that they need blood pressure checks, blood sugar checks for diabetes. They need to monitor their medications if they're doing it on their own. They need to exercise as tolerated and that low sodium diet and fluid restriction. So what about safety during and after dialysis? That bleeding from the access is a common thing. Just the other day, I was in a dialysis unit. Patient was in a hurry. He held his access sites. Then he got up from the machine and started dashing toward the scale, and his access started bleeding again. So we had blood dripping on the floor. We had to set him back down and had to hold pressure on that side again and clean up the floor and the chair and all things in between. So bleeding from the access can occur. Hand hygiene is important, and catheter infection prevention and fall prevention. Hypovolemia and hypotension, we need to teach the symptoms: dizziness, nausea, cramps. Hypoglycemia, they need to know anything under 70 is not acceptable, and to review the symptoms and treatment. So patient education and fatigue. Fatigue is probably the most common complication following dialysis and is generally correlated to the amount of fluid being removed. Exercise can help fatigue. Instruct patients to exercise to tolerance early on the days off of dialysis. Walking is the best and safest exercise. Patients should collaborate with the interdisciplinary team if fatigue is preventing normal activities of daily living. There is an option for in-center self-care hemodialysis, and that's while it is not commonly used often, there is another hemodialysis setting for patients able and motivated to do self-care, but who have barriers to home therapy, as discussed in Module 6. This option is in-center self-care dialysis. With this option, the patient performs part or all of the treatment process in the dialysis center. This is unusual in the United States, but it is popular in Europe and Australia, especially for patients whose homes are not suitable for dialysis or who need some staff support. The nurses and staff act as educators and provide a support system. The option is not only allowed by federal regulation, but it encourages it, as evidenced in the quote from the regulations in 2008. And the quote is there on your screen. If a patient expresses the desire to perform self-dialysis in-center, the facility interdisciplinary team's response should incorporate assessment of that patient for self-care training and planning for the goal of self-care as appropriate. Self-care in-center hemodialysis is a modality of hemodialysis where the patient performs part or all of the treatment process in an in-center setting. The nurses and staff act as the educators and support system, guiding the patient from a state of total dependence to a state of independence. And if the home situation is suitable, the patient may even transition to home hemodialysis. So self-actualization here, Bray talks about, and quotes here, the modality which introduces the patient into a continuum of care ranging from dependency to independence. Greater knowledge of the dialytic process itself is achieved. It is thus a means by which patients can again achieve an active and meaningful lifestyle associated with the feeling of physical and emotional well-being. So the theoretical basis of self-care is the concept of self-care dialysis aligns with Orum's nursing theory. The self-care deficit nursing theory developed by Dorothea Orum was based on a philosophy that all patients wish to care for themselves. So restoration to health and well-being is achieved more quickly and holistically when the patients are allowed to care for themselves. There are three requisites: universal, developmental, and health deviation. If these requisites are not met, a self-care deficit occurs. This is where the nurses shine. Nurses determine these deficits and define a support modality to meet them until such time as the patient is able to assume their care himself and point them to the when the deficit no longer exists. So in other words, the patient's able to assume self-care and there's no deficit any longer existing. In doing so, patients are enabled and empowered to care for themselves, knowing that they have a partner in care, the nurse. Together, the nurse and patient can explore the self-care dialysis options available. Nephrology nurses actualize this with the aid of the scope of practice and standards of care, knowing that patient control is in the learning process and personal involvement in the treatment and rehab process increase adherence and improve quality of life. And in doing self-care, so many patients can also realize the more subtle benefits of self-management as outlined here by Roberta Curtin's definition. Self-management includes patients' positive efforts to oversee and participate in their health care and optimize health, prevent complications, control symptoms, marshal medical resources, and minimize the intrusion of disease into their preferred lifestyle. Staff-assisted peritoneal dialysis. We're only going to talk a little bit about peritoneal dialysis, or PD. It usually occurs at home. Self-care therapy may be an assisted therapy in a hospital long-term care facility. If the patient is in the hospital and needs to start dialysis urgently, it is becoming more common for a PD catheter to be placed rather than the central venous catheter, because the central venous catheters become infected so easily and cause harm to patients. So the hospital dialysis staff will do a PD treatment with a machine, and the patient will later be trained to do self-care PD once they are discharged from the hospital. If the patient is already on PD and is hospitalized for acute care due to another condition, they may not be able to manage their PD as well and will require help from the hospital staff. Non-nephrology nurses will be involved with their general CKD management, especially diet and medications, which are very similar to those but used by patients on hemodialysis. There are also some patients receiving PD and long-term care who are unable to perform their own treatments. However, staff at those facilities are specially trained to assist the patient. More information on PD can be found in Module 6 of this series, which details home dialysis. So here we see a depiction of a patient with a PD catheter placed in their abdomen. You see the abdominal cavity there with the outline of the peritoneum. And we see that peritoneal dialysis uses the peritoneal membrane as a filter. It's accessed by the implanted peritoneal dialysis catheter. We see that bag there. The bag is the dialysis solution. So we let that dialysis solution flow into the patient's cavity. Then we clamp it off and either disconnect the bag or fold the bag. It depends on what supplies you're using. But then the patient goes on about their day, and they may do 4 or 5 exchanges like this every day. So during the draining process, we would connect the drain bag and let the patient drain and then refill with fresh solution. So it's really a flushing of their belly, and it does take out the uremic toxins and fluid. So here you see a patient doing continuous ambulatory peritoneal dialysis, or CAPD. He's sitting there with the drain bag on the floor, and then we have the fresh bag up above. We have clamps in place so that we can clamp after we're done draining, and then open the clamp to the fresh bag and let the dialysate flow through the patient's transfer set and into the abdomen. Then on the right, we see continuous cycler peritoneal dialysis, or CCPD, also called APD. We use a machine there. It has a warmer on top and a large bag of fluid is put there. We attach the patient to the lines, and the machine opens clamps and closes clamps during the night while the patient sleeps. So we're filling and draining during the night. The summary of the U.S. RDS kidney replacement therapy prevalence data is here on this slide. The number of people in the U.S. experiencing CKD leading to kidney failure are growing, so there are more needing kidney replacement therapy every year. These data show that the overwhelming majority of our kidney failure patients who are receiving life-saving assisted hemodialysis in-center are elderly, have serious comorbid conditions also requiring treatment, and who don't have the life expectancy that the younger, healthier patients doing self-care or living with a kidney transplant have. But we nephrology nurses know who have given care. But what we nephrology nurses know who have given care to these patients many hours per week over the span of many years is that patients are there for quality of life, if not quantity. If their wish is to see children and grandchildren grow and prosper, weddings and graduations to witness, and the chance to hold that newest baby, we need to give that to them. And the Kidney Disease Quality of Life Survey, published in 2018, supports that knowledge. Our patients know better than anyone that life is difficult, often painful, and inevitably short. We know that many of you share our care of them, and please see the next module in this series on how we can offer patient-centered quality of life care at the end of life. And we thank you for being in attendance today. So this was Module 7, Kidney Replacement Therapy, Assisted In-Center Treatment. We thank you for the care you give our patients in CKD and kidney failure, and for choosing to learn more about them and their therapies through these modules. There is a PDF handout that you can download, the slides, the narrative, and glossaries are there. These are all the authors and reviewers that helped Leslie with all of the modules, and we thank them for their help. And here we have Leslie. We thank Leslie. ANA extends its heartfelt appreciation to Leslie Dinwiddie for her unwavering dedication to the revision and enhancement of the CKD modules. Leslie led every step of the process, from selecting authors and reviewers to guiding the content development. ANA is grateful for her expertise and commitment to this important project. Thank you so much, Leslie. And here we have the references, which you can also download in a PDF format from the website. And we thank you.